Okay, welcome. This is going to be a presentation focused on cancer prevention for the practicing oncologist. And what I'm going to do, I serve as the Vice President and Head of the Division of Cancer Prevention and Population Sciences at the MD Anderson Cancer Center in Houston, Texas. And I'm going to share with you a little bit about how we provide prevention services at a large cancer center. So first of all, disclosures, I have consulted with a couple of companies working in prevention. They're described here, but none of the content that I'm going to share with you today has any interactions whatsoever with those past commitments. To begin, there's a lot that we can do to prevent cancer in 2019. It's estimated now that a third to a half of all cancer deaths are preventable in the United States and other Western populations. So that's a very important message. But to realize the potential of prevention, it needs to be affected in two domains. First of all, in personal actions that are taken every day by every individual, and we'll summarize those here on this slide. They're captured in the yellow box. Complementing those activities on a personal basis, most often communicated in a clinical context, will be population-based actions. And the actions are largely the same. The challenge is delivering them both to individuals in a clinical context as well as to the population as a whole, so that the healthy choice is the easy choice and the one that serves as a default. So first of all, a quick summary of the personal actions that are important to reduce cancer risks, maintaining a healthy weight across the lifespan. Second, avoiding known carcinogens, the most prominent being tobacco and alcohol. Third, eating a healthy diet and being physically active. Fifth, knowing your family history and communicating that to family members. Next, avoiding excessive natural or artificial UV radiation or sunlight. Really important because skin cancer remains the most common cancer in most populations and certainly here in the US. Seventh, following a cancer screening program. So now we have many evidence-based actions that we know result in reductions in cancer mortality. So availing yourselves of those tests when they're appropriate is one major way that we can reduce cancer risk. And then finally, there are now some 14 or so FDA-approved agents to either reduce the risk of cancer or to prevent cancer. And so availing yourselves of those, again, in a clinical context, are very important. So now we'll go into how those services are delivered at a major cancer center like MD Anderson here in Houston. And we offer a cancer preventive services in our Lyda Hill Cancer Prevention Center. It serves now roughly about 50,000 patient visits per year. And we deliver our care in 5 domains. First of all, risk assessment. That includes things like both qualitative as well as quantitative assessments of an individual's risk for one or more cancers. And the examples here for breast cancer for women using something like the Gale model, as well as offering genetic testing when that's appropriate based upon one's history. Next domain, prevention. And there we're talking about advancing healthy lifestyles in a proactive manner, as well as providing access to medical and surgical interventions that can reduce cancer risk. Next, of course, offering cancer screening services. And as I mentioned, we have 4 or 5 now that are evidence-based and known to result in reductions in cancer mortality for the general population. And then for high-risk individuals, in many instances, we'll offer additional screening. Next on the list, tying screening into action, or that is moving from a screen positive state out to a diagnosis with subsequent interventions, very important. So we offer specialized entry into diagnostic services as well. And then finally, our center is progressively becoming not only a cancer prevention center, but a survivorship center as well, as we take patients that have completed their therapy successfully in one of our treatment centers. And our prevention center offers a bridge back to primary care, many times offering specialized services in survivorship that, again, I'll cover briefly toward the end of the presentation. But beginning at the beginning, let's talk a bit about familial and genetic risk. So first of all, why is that important? Well, it's important because it guides many of, it not only informs, but guides some of the subsequent actions. So knowing one's hereditary predisposition to cancer can help a patient understand why they developed cancer in the first place. It can provide information about subsequent risks for second cancers. Many times an individual with a cancer will be at elevated risk compared to the general population for a second cancer in that site or elsewhere. Third, that knowledge or information shared between a clinician as well as a patient can inform subsequent decision-making for things like screening options. Many times, depending on the age of the cancer, the frequency, when the cancer occurred can determine the subsequent actions in terms of the type of screening, the frequency or intensity. Next, it also will many times inform blood relatives of their cancer risk and therefore put them on a different screening schedule or clinical risk assessment process. Next up, many times these days, knowledge of genetic risk can also guide treatment options for a diagnosed cancer. And then finally, of course, many times these days, that knowledge is informed in clinical trial opportunities as well. So what oncologists are recommended to do is, first of all, take a complete family history, as well as personal history for the patient in front of them, and document that in the medical record. It's important for practicing physicians to be current on recommendations and guidelines for both referral as well as genetic testing as well, and those are available from any number of sources. I highlighted 3 of them here. The NCCN has genetic testing guidelines. The U.S. Preventive Services Task Force has them similarly, and many professional organizations such as ASCO or surgical groups will publish those on a period and update them on a periodic basis. The premise for all of that is a accurate and thorough family history, and what we do here is recommend gaining knowledge regarding cancer that have occurred in first, second, and third degree relatives, documenting that again in something like a family history algorithm, noting the age of each of those relatives, the time of a diagnosis of cancer, important to capture issues relevant to ethnicity as well, since some cancers tend to occur more so in some ethnicities as opposed to others, and then noting the presence of other chronic diseases. And all of that is captured at MD Anderson in treatment algorithms. This is displaying our genetic counseling algorithm as one example, but you'll see this is just page 2 of 8. So these are much larger and more complex than I have time to review, but I more or less wanted to make sure that you are aware that they're available. And you'll see a hot link there at the bottom of the page if you're interested in any of these that I'll share with you. They're publicly available on the web. Next, we'll move on to a little discussion around what we do in prevention. So one of the things that we've done over the last 4 or 5 years, as the evidence has accumulated and become more and more convincing that healthy lifestyles are important in reducing cancer risk, is we specifically try to make sure every encounter we have with someone who's otherwise healthy visiting our cancer prevention center is comprehensive in scope. So they may come here for breast screening, but we want to try to intentionally make sure that we're addressing the full spectrum of contributors to cancer risk. And so this is something that we've termed our Integrative Health Initiative, and it focuses on activities in 5 domains across our campus. And in the Cancer Prevention Center, we highlight 3 of them in particular because of their known association in boosting cancer risk. And so we'll now talk about how we approach nutrition, physical activity, as well as tobacco and their association with cancer risk. So first of all, as I mentioned, we have a dedicated effort now to try to promote healthy lifestyles in the Cancer Prevention Center. Our mid-level providers, as well as our physicians and nurses, all take this very seriously. And so we attempt to offer a comprehensive program. Their expertise is complemented by dedicated individuals such as health education specialists, registered dietitians, exercise specialists, who can go a bit deeper than the time usually allotted to busy clinicians, so that we can really emphasize and help patients make these healthy lifestyle choices. Some of the challenges, of course, are the reimbursement is still lagging for this kind of advice delivered in a clinical context. And also, many of our patients are used to coming back for an annual exam or an annual mammogram, for example. And so trying to stimulate their understanding and their commitment to making healthy lifestyle changes is also a challenge. Motivational interviewing has become a very important part of what we do. Another important part of what we do is captured here. And it's a tool that we've developed and now put in place by among several of our practitioners to take, again, what would otherwise be a focal encounter and make sure it's comprehensive. So we've developed something termed the MD Anderson Health Index that's shown on the right-hand side of the screen. It covers very fundamental, simplistic approaches to assaying a patient's status with regard to 11 risk behaviors. And again, this is extremely simplistic. It's meant to be self-administered, typically in the waiting room before a clinical encounter, and then shared with the practitioner at the time of the visit. And fundamentally, we sum the scores very quickly, and it gives us a general guide as to whether an individual is already following all of the recommendations for a healthy lifestyle or whether there's work to do. So it's a way to highlight the importance of these issues broadly across our entire patient population. This was developed in-house. It's been put in place over the last year or so by a couple of our providers. We've tweaked it several times to try to make sure it's useful. We have personally found it useful. It's now undergoing dedicated study. And we are also using it outside the institution in some discussions with local provider health clinics, minute clinic sort of contexts, to again try to make sure that every encounter is reinforcing the importance of healthy lifestyles. And now we'll get into a little bit about what we recommend and why we recommend these actions in our Cancer Prevention Center. So beginning with physical activity. And this is I've largely in this presentation concentrated on summaries of the existing evidence in order to make sure that I don't highlight one study over another. So these are largely literature compilations. And this is showing the literature as it exists from a recent compilation around physical activity and cancer risk. That is the risk of developing cancer or cancer incidence. And you'll see here across some 15 or so cancer sites, there's now strong evidence that we believe to be actionable for 6 or 7 cancers associated with physical inactivity. You'll see the risk reduction that's anticipated, excuse me, is on the order of 20% reduction in risk with those who are most active compared to those who are most sedentary in these largely observational data sets. But it's now consistent across studies and felt to be actionable and compelling. And you'll notice that many of them also have a dose response. That is, the more physical activity that one does, the lower the risk of subsequent cancer development. This contrasts with for several cancer types where we don't yet have compelling data shown at the bottom of the slide. But nevertheless, 6 or 7 cancers where we believe this is a very important risk factor. On the right-hand side of the slide, I'll show you the complementary data, not for the risk of developing cancer, but for mortality among cancer survivors. And again, at least for breast, colorectal, and prostate cancer, there's now at least moderate evidence of a substantial reduction in risk among those who are most active versus least active, both related to cancer-specific mortality, about a 40% reduced risk when more physically active, as well as for all-cause mortality, again, bringing in cardiovascular benefits. So we think this is very important to highlight for our both our at-risk population as well as survivors. Physical activity is related, of course, to body fatness, and now we know that obesity is linked to increased cancer risk at some 13 different sites that are captured in this slide. You'll note there's sufficient evidence underlying that association for these 13 cancers. The risk associated with obesity can be very mild, something like postmenopausal breast cancer or thyroid cancer, ovarian cancer, 10% elevated risk among those obese versus not. However, in some cancers, this can be quite substantial. Here noting a almost 5-fold increased risk for esophageal adenocarcinoma and a 7-fold increased risk for uterine cancer. So again, a very important issue for our patients, and therefore has stimulated us to take action. And on the right-hand side of the slide, again, those cancers for which there's limited or insufficient evidence to suggest an association between obesity and cancer. I'll note that we don't yet fully understand the reasons for this association, but nevertheless, it's been consistent and therefore felt to be actionable. On this slide, I've tried to summarize quickly what we recommend patients do about this. So on the left-hand side of the slide are physical activity guidelines, and I'll note these are drawn from other expert bodies. Largely rely upon both the Sports Medicine Society as well as the AICR and their recommendations in what to suggest to our patients. And they tend to be quite simplistic in nature. Of course, most of this doesn't come out of randomized controlled trials, but large observational studies. So randomized trials are ongoing in many cases, but right now our general recommendations are to move more and sit less throughout the day, to try to target at least a half an hour of moderate intensity or more of vigorous intensity physical activity. And we describe that as moderate intensity, meaning that you can still carry on a conversation, but it may be uncomfortable. Vigorous intensity, unable to really carry on a conversation when working at that level. Also, we note the additional health benefits that are to be gained, particularly cardiovascular benefits. And we also recommend muscle strengthening exercises a couple of days a week. On the dietary side, again, this is more or less what your mom taught you. But generally, we strive for the suggestions that are made here. Concentrating on whole grains, fruits and vegetables being at least 2/3 of the plate, avoiding or limiting fast foods, foods that are high in energy but low in nutritional value, limiting the consumption of red and processed meats because of their strong association with colorectal cancer in particular, limiting consumption of sugar-sweetened drinks, of course, limiting alcohol consumption, and not relying on supplements for cancer prevention. That's very important. Many of our patients think that a vitamin supplement will protect them against cancer. And as you probably know, most of those studies, and in many cases randomized trials, have not shown a protective benefit, and in some cases have even shown an increase in risk, at least in subsets of the population. So once again, we've taken all of this advice and distilled it down to clinical algorithms that we have in place here on our campus. Again, readily available on the web for anyone interested. I will say that these, in particular, physical activity and nutrition, were hard to come by. We didn't see many examples in the published literature, and our experts spent quite a lot of time in compiling them. In every one of them, we rely upon a systematic upfront evaluation of the need for referral. Second, a defined trigger for intervention, suggesting action. Third, all of them, because we're dealing in the domain of behavior change, they all rely upon motivational interviewing and monitoring. And then finally, there's an assessment component in each of them because it's important to not only advocate, but also assess and follow up and continue to encourage patients as they adopt these healthy lifestyles. Next, I want to share just a couple of slides around how we handle tobacco. So again, this is the most prominent cause of cancer and cancer death in the American population, and certainly in Texas. We, in our largely cancer patient population, as well as in the prevention center, find it still to be relevant. Even though many feel that, oh, well, that's an old issue and it's taken care of, we find that's not the case in our patient population. Some, as many as a third of our survivors smoke, depending, of course, on the type of cancer they may have suffered. And higher rates of smoking are self-reported by cancer patients at diagnosis. We believe it is a teachable moment. And we rely on evidence such as compiled in the 2014 Surgeon General's report on 50 years of progress against tobacco in terms of what we suggest to our patients. First of all, there's sufficient evidence to demonstrate causality between smoking and a range of adverse health outcomes, surely increased all-cause mortality, cancer-specific mortality, as well as the risk of second primaries in a cancer patient. But there's also suggestive evidence of poor outcomes associated with treatment, and all of that our patients find to be quite motivating. So what do we recommend? Well, we, like other organizations, have now put together defined guidelines for action on the part of busy oncologists as well as others on the care team. Both ASCO and AACR suggest that every patient should be queried about their smoking status and then with intervention to follow if indeed there's a positive response. And what we find from the best surveys are that 90% of oncologists routinely ask, 80% advise patients to quit, but rarely, 30–40% in these data, are they able to offer quit assistance. And so that's really the gap, and where we've tried to develop a program to refer patients in order to receive these kinds of interventions. And fortunately, in 2019, there's a lot that we know that we can impart to try to advance patient success in quitting. At MD Anderson, we have a very well-established tobacco treatment program that's been in place for the last 12 years or so. We use state tobacco funds to support this activity specifically. It's offered to all active smokers as well as recent quitters, quitting within the last 12 months. We offer this to patients and their family members, as well as to our own employees and their dependents. It's really important around tobacco to treat not only the patient, but also the context in which they smoke. And that's why we extend these services to patients' family members as well. Our treatment involves an initial clinical assessment by a clinical psychologist most often, or a addiction psychiatrist, using a standardized questionnaire, and it is all documented in the medical record. Next, we move on to treatment, and we rely upon a combined strategy of both behavioral intervention based on cognitive strategies, typically 6 to 8 clinical counseling sessions, and with follow-up at 3, 6, and 12 months. We also provide paid pharmacologic support using any of the FDA-approved interventions, and we make sure to schedule follow-up phone calls or appointments in order to check on patients across their quit journey. Our program is quite successful, achieving quit rates of about 35 to 45% abstinence at 9 months. I will also highlight that another thing that we did that really helps this program across our entire campus, we now use our EHR and the simple questions about whether you smoke or not to automate the referral process into the tobacco treatment program. We found these data on the right-hand side of the slide are showing the success. We had about 10 referrals per day with provider-based referral. And when we flipped the switch on the EHR, automated referral went up 3 to 4-fold. So that can be a very important strategy in getting this service to patients who need it. And we now also offer accredited certified tobacco treatment specialist training that's highlighted here. There are about 19 or 20 such programs across the country. We offer this as well as a 5-day course where an individual, not necessarily a physician, but any level provider, can come and be certified in tobacco cessation treatment. And just as with all of our interventions, this has been now captured in a treatment algorithm, and this is page 1 of 7, again, readily available to you if you're interested. The next area we cover in the prevention domain is skin cancer prevention. So it's very important to educate patients about the association between UV exposure, ultraviolet exposure, and subsequent risk of cancer. And this is capturing some of the data points that we try to highlight for patients related to melanoma, basal cell, as well as squamous cell cancer. And I'll just run through some of the details here. It's intermittent sun exposure that is seen to be particularly problematic for melanoma. Sunburns in childhood are particularly concerning. Those who use indoor tanning facilities are at increased risk compared to those who do not, particularly early in life again. And this is showing those who indoor tanned at least 1 time per year. I'm sorry, I lost my slides. Here we go. So again, those who have indoor tanned, 60% increased risk compared to others. For basal cell carcinoma, frequent indoor tanning, again, a prominent risk factor, as well as early tanning. And finally, for squamous cell cancer, again, indoor tanning really elevating risks. So avoidance of tanning beds is one of the major messages that we give to patients. I will highlight that we don't suggest skin cancer screening to general populations. However, we do advocate behavioral counseling for particularly for parents of young children, adolescents, where because that early sun exposure or tanning bed exposure is so problematic. And what we recommend to our patients is captured on the right-hand side of this slide. Again, fairly common sense and straightforward, but nevertheless important for a practitioner to highlight for their patient population. Okay, so we've just recommended healthy lifestyles as being a very important part of clinical care. Why do we do that? Well, I've shared some of the evidence. Let me show it to you now, compiled around healthy lifestyle versus not. This is a prospective data from cohort studies as well as systematic reviews, 2 large studies, one from the NCI, the other from the ACS. You'll note that there are some 100,000 to 500,000 individuals in these studies with follow-up time extending out to 14 years. And recall, cancer is age dependent, and so we anticipate these data will strengthen over time. But already there is a noted 10 to 20%, perhaps even as high as 45% reduction in all cancer incidence among adopters versus those who don't practice healthy lifestyles. Second, there's a reduction in all cancer mortality, about a 25% reduction. Third, there's a reduction, of course, in cardiovascular disease mortality and reductions in all-cause mortality as well, 25 to as high as 40%. So for all of those reasons, trying to bolster the uptake in practice of healthy lifestyles is terribly important. I now want to move beyond healthy lifestyle into what we can do medically and surgically to reduce cancer risk. And of course, there's a lot. Captured on this slide are some of the things, the interventions that we know work, largely through randomized controlled trials. So first of all, vaccines. There are many examples there where we now have vaccines that can reduce cancer risk. Next, we have therapeutic agents, FDA approved to be safe and effective for reducing cancer risk or treating precancerous lesions. And there are some 14 that are marketed now. This captures some of the data around things like raloxifene or tamoxifen to reduce breast cancer risk, particularly in high-risk women, or fluorouracil, a whole variety of agents that are applied topically to treat actinic keratoses or precancers of the skin. And then finally, even surgical interventions have been shown to be cancer preventive, and I'll say a couple more words about those. So beginning with the perhaps best example of cancer prevention in a secondary context in practice in a primary prevention context is HPV vaccination. This is showing the results of some 26 trials that have been conducted since these vaccines came out about 12 years ago now, and you'll see very substantive reductions in terms of relative risk here for both HPV 16 and 18, which were, of course, the targets of the initial vaccines. Almost 99% reduction in risk among those vaccinated versus treated with placebo. And even for CIN3 lesions beyond the HPV 16-18 driven, a very substantial reduction in risk. So getting patients vaccinated for known causative agents related to cancer, terribly important action. And of course, HPV vaccination needs to be complemented by cervical cancer screening. That's what this is calling out specifically, another very important action to reduce risk of cervical cancer. I'll have more to say about that in a moment. Breast cancer prevention, another area where randomized trials, this one's highlighting the NSABP P1 trial that showed substantive 50% reductions in risk for both invasive breast cancer as well as non-invasive breast cancer among those randomized to tamoxifen versus placebo with about a 5-year follow-up interval. And so now ASCO has come out specifically, and just earlier this month, come out with recommendations around endocrine therapies for breast cancer risk reduction. And this is highlighting that both aromatase inhibitors as well as SERMs prescribed daily for 5 years significantly reduce the risk for high-risk women. And this is showing the various risk strata, who might be eligible, captured there in the blue in the small box. And once again, we have MD Anderson treatment algorithms that are related to breast cancer risk reduction if you're interested. I also wanted to highlight the importance for those who are substantively obese and been unable to lose weight, that bariatric surgery has now been associated with substantive reductions in cancer risk. This is highlighting, again, a summary of some 32 studies looking at all-cause mortality, cardiovascular disease, as well as cancer, both in non-randomized controlled trials as well as cohort studies, a consistent story of about a 30% reduction in cancer risk among those undergoing bariatric surgery versus not, and about a 38% reduction in all-cause mortality. So even something as dramatic as bariatric surgery, we know it's done with one intent in mind: it can reduce cancer risk as well as all-cause mortality when properly applied. Next, I wanted to highlight data, recent data for less dramatic approaches to weight management. This is showing data from the Women's Health Initiative involving some 36,000 women with 11 years of follow-up. And what this is showing is a substantive reduction in cancer risk, in this case, endometrial cancer risk, among women who lost weight versus those who did not. So an associative study, observational in nature, not a randomized controlled trial, but suggesting that significant weight loss, either by, in terms of, this is showing change in pounds in the top panel there, at least 10 pounds or greater, about a 50% reduction in endometrial cancer risk. And even when looked at in a percentage of overall body weight, a 5% loss of weight, about a 50% reduction in subsequent endometrial cancer risk. So again, healthy lifestyles matter. Next, I'll move on to screening, and this is the single slide that captures everything we recommend in screening, both for women as well as men. We largely follow the U.S. Preventive Services Task Force or the ACS guidelines, but some of our details differ slightly. Nevertheless, all of those bodies recommend evidence-based screening. And I'll now quickly run through the screening tests that we recommend in our Cancer Prevention Center. First of all, cervical cancer screening, very important, and estimated mortality reduction that's very high, 80 to 90%. So along with HPV vaccination, cervical cancer screening, strongly evidence-based, highly recommended, particularly women between the ages of 21 to 65 by any number of methods. Next, breast cancer screening, again, a B-level recommendation for women 50 to 74 years old. That's because the mortality reduction is estimated at least 15%. For younger ages, more of an individual decision made together between provider and patient. Prostate cancer screening, this has been all over the map over the last decade or so, but now recommended to have a discussion for men between ages of 55 to 69, considering both the potential benefits in terms of mortality reduction, but also the significant harms that can be associated with subsequent intervention for prostate cancer screen positives. But an estimated mortality reduction in some of the studies, at least on the order of 20%. Colorectal cancer screening uniformly recommended, I think, by all such authoritative bodies. This highlights in particularly the American Cancer Society that now recommends that adults be screened as early as 45 years of age, an A-level recommendation strongly associated with reductions in mortality anywhere between 15 to 50%. Hepatitis B, very important to be screened for. Of course, there's neonatal vaccination. That's probably the most important, but for particularly those who were not vaccinated as infants, important to screen for hepatitis B because of the substantial reduction here in liver cancer risk, 43% estimated among those who undergo screening. And similarly, hepatitis C screening should now be offered to all who are baby boomers born between 1945 and 65, B-level recommendation. Very important because now we have effective therapies that can be delivered over just a few months with very substantive risk reduction for liver cancer. Lung cancer screening is one of the newest such screening tests that are offered, and it's because of these sorts of compelling data of the NLIST as well as the Nelson trial suggests about a 20% mortality reduction screening by annual CT among those at high risk, particularly 55 to 80 years of age with a smoking history of at least 15 pack years. I want to, again, highlight that all of those screening tests that I went over rather quickly, in many cases, there are a variety of different interventions that can be applied. All of those are captured in our algorithms and progressively moving away from simple age-based recommendations to more personalized and tailored suggestions related to individual risk. Again, why that initial H&P is so important. And here I highlight the screening algorithms that we have available, some 10, 15 different sites about how we do it at MD Anderson in case you're interested. Moving on now, downstream of screens, what do we do with screen positives? We're able to offer 3 varieties of what we term undiagnosed clinics for breast, cervical cancer, as well as skin lesions. This results from our own screening efforts, or in many cases referred into our institution from a local primary care physician who's got a funny report and they would like it considered by our prevention experts. So we offer same-day quick appointments in our undiagnosed breast clinic, same-day consultation and confirmatory testing. We typically try to refer provide a diagnosis within about 2 days. And with subsequent referral either to our cancer prevention center, if it's not found to be a cancer, or if it is, into one of our treatment centers. And again, this is the breast example, but we have similar clinical operations for cervical lesions as well as skin lesions. The last domain I wanted to cover for you quickly is in cancer survivorship. I mentioned that fortunately the population of survivors is growing in Texas, in the nation, and around the world. And we think it's important to systematically pay attention to at least 4 domains, and they're captured in this slide. First of all, surveillance for recurrence or second primaries. Second, monitoring for late effects of treatment. Third, risk reduction and early detection either for a second primary in the primary organ or at another site, since almost all cancer is strongly age-related. And then finally, psychosocial support to try to return a cancer survivor back to the sort of lifestyle that they had before the diagnosis. And this is just one example of our breast survivorship algorithm. And you can see here the 4 domains that are covered there, again, in a much more detail than I can provide for you in this quick summary. And we have now 30 such survivorship algorithms, and this shows the full array of what's available readily to the public and available on the web should you have interest. I also wanted to point out that aligned with the American College of Surgeons Commission on Cancer, we offer a cancer treatment summary to all of our survivors when they're leaving their clinical provider. And this is highlighting one such example of someone who had a breast cancer in the past. They were treated by Drs. Smith and Jones. So we provide a summary of their care. And we highlight in the passport, what we term a passport, the areas for either our own practitioners or another practitioner outside of our institution to pay attention to in the green, as well as the recommended surveillance and prevention measures that should be taken in the green. In the purple and in the green, respectively. We find this is very well received by both the patients as well as primary care physicians to try to assure that the cancer care they received at our institution is extended out both in time as well as geography. I want to highlight the importance of attending to the whole patient and taking a holistic approach to prevention and health promotion. Because just as this slide captures, for a breast cancer survivor, when you get out past 10 years, the greatest risk is actually for cardiovascular disease mortality, not necessarily recurrence and death from their breast cancer. So that holistic approach of trying to help prevention broadly is very much on our minds. Fortunately, in the United States, as of 2010, the Affordable Care Act really brought greater attention and focus to preventive service delivery. And captured here are the array of screening tests as well as preventive services that can be reimbursed because they are recommended by the U.S. Preventive Services Task Force at an A or a B level. This is highlighting that these should be offered to individuals according to defined schedules with no copay for anyone who has insurance either through the government or through a commercial provider, for example, or a commercial agent, for example. So this is very important because it really prioritizes and removes one of the major barriers, that is cost, around receipt of these services for insured individuals. We still have an issue, unfortunately, in uninsured populations. But all of this has been proven to be effective, and I've highlighted how we deliver these services earlier in the presentation. Let me just end by highlighting that this is what we try to do, but still achieving prevention of cancer or other diseases is a challenge, both within a clinical as well as a population context. And Harvey Feinberg was a speaker here in our cancer prevention grand rounds on our campus about 8 years ago. And we asked him if he would commit what he had shared with us to writing, and he subsequently did and published it in JAMA in 2013. For anyone interested in prevention, this is really a wonderful piece, and I wanted to bring it to your attention. He highlights that prevention is challenging because unlike in a therapeutic context where we can really change the fate of an individual, in prevention, there's no drama. Many times we're talking about statistical lives. We'll never know if the action that we take in the patient sitting in front of us is really effective in decreasing their risk or saving them from a diagnosis of cancer that may be beyond our interaction. Of course, we're looking for something not to happen. Many times for payers of preventive services, they complain that, well, we'll invest today, but the real result won't come for 20, 30 years thereafter, and therefore that investment may be lost. It isn't worth our investment in order to see that long-term benefit that may accrue to a different payer. That's true, but it's terribly important to try to promote healthy lifestyles in those within our spheres. Another challenge, advice changes. Of course, science moves on and we learn new things. So that's not a problem just for prevention, but it is a problem for prevention because so much of what we know about prevention is of interest to the general public. So every other day, there's a new piece of data coming out because of general interest in issues like nutrition or physical activity. He highlighted that many times there's a double standard in evaluation of preventive and treatment services, that there can be commercial conflicts of interest, and sometimes prevention practices may conflict with personal or cultural beliefs and approaches. Think of something like the importance of tobacco to some Native Americans' rituals that can be very difficult to overcome. But the good news is he also left us with the positive side. There are many strategies to try to overcome those and other obstacles. And some of what he shared with us is captured here. Paying a little bit at least for prevention, because many times people value what costs them a little bit. Secondly, trying to make prevention cheaper than being free. So I already highlighted the importance of the Affordable Care Act. If we can even make it the easier choice and something that doesn't cost patients, perhaps uptake could be more consistent and profound across a lifetime. Involving employers or other payers, very important. Trying to make this a part of all of the lives of our patients, such as where they work. Re-engineering systems so that, again, the healthy choice is easier to make. And then finally, using multiple channels, comprehensive strategies, just as has worked in tobacco control over the last 50 years, are some of the strategies to try to deal with the obstacles. So I've covered a lot of territory, and I've tried to concentrate specifically on what a clinician can do in the patient sitting in front of them to try to promote prevention and healthy lifestyles. I hope this has been of use to you. I've left my contact information here on the last slide so that hopefully you can feel comfortable reaching out to me if there's anything we can do to try to assist you in your adoption of these kinds of practices, advice, and suggestions in your own clinical practice. Thanks very much for your attention. Happy to take questions online.